And that today I'm a bit busy, so we will be having a brief session. So, as I send the topic, like what is the concept of team? So, what different teams have you heard related to anesthesia and critical care? Yes, Atik bhai.
Sir, in anesthesia, there are multiple roles that have been played by in coordination with so many people. And team is, what is team? Team is the group of people who work work as a team, work as a group to maintain some achievement, to attain some mission, or to attain some objective, like rapid response team, and and so another one is sir code blue team. Another one is management disaster plan team. And sir, another one is some, there can be any code
like if you divide, just think about it, that things related to emergency, like you told, rapid response team. Okay, this one code blue team. Okay, then there is one other team which is related to critical care as well. We
critical outreach team, sir. Critical care outreach.
Okay, so now come one more emergency which may be faced. Like it's not sort of emergency, but there is a team which is there dedicated in specialized hospitals. That is difficult venous access team. Okay, difficult venous access team. Okay, then another team which is we can be dealing is anticoagulation team. It's actually that part of this one cardiologist usually. Okay, and their duty is to manage any patient who are on any anticoagulants, and they are going they are being planned for any procedure or anything in which that anticoagulation needs to be management and carefully taken care of. Okay, so that team is the anticoagulation team. Okay, then there can be the related to pain. There is one acute pain APS team, and then one is chronic pain or palliative care team. Okay, so these are different teams which are like in anesthesia care we are dealing with. Okay, so like any other team which comes in the mind? Acute pain service, chronic pain service, palliative care, rapid response team, code blue team. Then I told you IV access team, critical care outreach team, anticoagulation team. Okay, so these are the different teams which we can come across. Okay, COVID team, yes, organ donation, yes, absolutely perfect. So recently this because even in the countries where there are some religious problems, there is some justifications from the religious leaders, they had been implemented. So organ donation is another team which you can come across. Anything else?
Sir, counseling team.
Okay, counseling team.
Team
you
which
can say that acute pre-anesthesia assessment team. Okay, pre-anesthesia assessment team can be there, which are evaluating the patient in either in the clinic or they are doing inpatient consultation. Okay, like the patients which are not coming to the clinic and they are admitted. And yes, acute trauma care team. Okay, acute trauma care team, which is actually providing the trauma care in the form of ATLS, and they are also doing the, as you mentioned, disaster team. So these are the different teams which you can come across. So we will start from rapid response team. Okay, because some of the components of all the team will be, because anesthetist or ICU intensivist, because in Pakistan, because anesthetists are covering ICU as well. So the things are a little bit different here. But like in some part of the world, like American system, or like I am working in Saudi Arabia, so ICU is separate. But even then, if you are working in anesthesia, you can say use the word of intense ICU doctor or ICU personnel whenever it's appropriate. Okay. So what is the concept of rapid response team? What is the purpose? Yes, Tayyiba?
So this is basically a group of health workers who can basically assemble quickly to deliver the critical care expertise in response to the grave clinical deterioration of the patient. Before it is basically a team which
What is the
assemble
basic?
quickly and deliver the.
If you just use, rather than so much difficult words, if you just very simply tell that what will be the main purpose of this rapid response team, main purpose, very simple.
To pick the clinical deterioration of the patient quickly outside the critical care unit.
Okay, fine. But actually the purpose is to avoid cardiac arrest. Simple words. Okay. Like on the basis of early signs of deterioration, they don't want the patient going in total decompensation or cardiac arrest. Okay. So this is the main purpose of rapid response team. So usually who will be activating this team? Usually
the primary nurse.
Primary nurse. Okay. So on which basis this will be activated? What is that called?
They're on the hemodynamic and the clinical deterioration in the condition of the patient.
No, there are some
score. Sir, a single parameter score or early warning score, sir. Here both are.
Single parameter score or early warning scores. Okay. Early warning scores.
That is a MEWS? MEWS?
No, MEWS. Listen, just relax. If it is used for maternal, it's called as MEWS. If it is for pediatric, it is PEWS. Or if it is for any adult, it is called as early warning score. Okay.
Okay.
So usually, what are they?
So they're basically 5 or 6 parameters on the basis of which we decide the systolic BP, temperature, heart rate, the respiratory rate, the SATs and FiO2 of the patient.
No, I think can anyone add to it? I think it is less than that.
So there are 6 parameters.
6 parameters. What are
6
those?
Parameters.
Because
first of all is heart rate. If it is range between if it is less than 50 or it is more than 130.
Okay.
And respiratory, the second one is a respiratory rate if it is less than 8 or more than 30.
Okay.
Third one is systolic blood pressure if it is less than 90. And fourth one is the conscious level. If any conscious level deterioration, respond to pain or any response or unresponsiveness. Number 5th is temperature. If it is more than 39 or less than 36 degrees centigrade. And the last one is oxygen saturation. If it is more than 95% or less than 90%.
Okay. Because you see, that's how even we correct our concept, because I was thinking it only on the, like I was not considering temperature and saturation in my concept. Okay. So any deterioration in conscious level or hemodynamics? So, okay, fine. So that will be activated. So who will be the partner in the team? who will be the part?
Sir, it is either it is the anesthetist, respiratory physiotherapist, or medical officer dealing with the critical care, charge nurse, and so this ICU nurse, primary nurse.
Okay. Who else?
On sir, the intensivist, the charge nurse, respiratory therapist,
Pharmacist.
and
In all these teams, don't forget pharmacist. Pharmacist is always in any time. Okay. And UEL activator is the nurse, but it can be activated by any medical personnel or even family member. He will be the primary person to respond, and then he or she will be calling the nurse who will be activating, nurse or doctor. Okay. So like that, and it will be hospital based. There can be adaptations or modification according to the hospital protocol. Okay. So
response team, rapid response team is also called as medical emergency team.
Medical emergency team. Any
both are synonymous, sir. But
Yes.
somewhere it is called MET, or somewhere it is called rapid response team.
Yes. Okay. So what about everyone knows about Code Blue team, but they have in this 2020 guideline, they have added one person in CPR team. What is that person, which was not there before? Anyone knows?
So it was the person who is counting their or recording everything.
Specific, no, there is a specific name. Yes, Tayyaba, you know it? Your hand is raised. It is CPR coach. Okay. It's named CPR coach. Okay. So CPR coach can be among the team members. Okay. And his or her responsibility, like CPR coach can be the person who is noting down the things. Okay. So that person, the responsibility of that person is to and make sure that the everything is going in an order. Okay. Like if heart rate, sorry, the compressions are not good, or they are too high or too slow, it's that CPR coach is the person who will be correcting it. Okay. Like it's a slightly different.
Sir, it means,
yes.
So sorry, it means that in addition to the team leader, we are basically, there is, in addition to the team leader, we are having one other person, which is CPR coach.
Actually, the team leader is the team leader. Okay. So because team leader was overburdened, according to them. Okay. So like overburden in the sense that there is a separate person who can be the person who is recording, for example. Okay. And his or her responsibility is to make sure that the team members are doing the things in an appropriate way, like quality of CPR. Okay. Like rate. Like this is the additional help to the CPR leader, the team leader. Okay. So this is
who should count the who should count the CPR compression as well, sir, and it should be quality wise, the 5 inches down, and it
like if they will be asking you in detail, you can tell like that. But if you can use in a precise word that this CPR coach is responsible to make sure the quality of CPR is not compromised. Okay. So how do we pull out the quality of CPR? On what parameter we say?
Sir, by seeing the internal carbon dioxide.
No. Just a second. That is one thing. Okay, fine. But overall, that is telling the compression quality. Overall CPR quality is, sorry?
Rate of compressions and the depth of compressions.
No. That's not. I don't think so. You people have done ACLS, or if you have done ACLS, you have forgotten everything. It is called as chest compression fraction, CCF. Okay, I forgot the number exactly. You can recheck. It's a chest compression
It should be
fraction.
100 to 120, sir.
No. You are not getting. That is something else. I'm telling chest compression fraction. Like for example, when you are any delays, they are how they are checking it. They are doing it with two stopwatches. One stopwatch, they are calculating the whole time. Okay, and the in the other they are watching the time for compression. Okay, and at the end, yes, it should be more than 80%. Okay, like minimum interruptions, they are calculating it because as much interruptions occur, the quality of CPR will be decreased. Okay, so total, for example, 10 minutes CPR, so the actual chest compression should be for more than 8 minutes. This is, I'm just giving you example. Okay, what will be the interruptions during CPR?
Sir, it is just it is the while giving shock. We should presume very less time.
No. What are usual compress? This is when you are shocking. This is the interruption. When you are changing switch user, this is the interruption. When we are checking the BP, checking the pulse or respiration, this is the interruption, or any other interruption during laryngoscopy or intubation. This is interruption. Okay, so this is the time in which you are interrupting. When you are analyzing the rhythm, this is the interruption. Am I right? So these are the times in which you are interrupting. So this is the concept. So one person is the team leader, one person is two person are on airway and compression, one person is usually on medication, and one person is the recorder. Usually it's a composition. So this CPR coach can be a separate person, or it can be among the people who are doing CPR. It can be anyone designated, and his or her responsibility will be like the recorder or medication person can be CPR coach, because the compressor or they will be doing one thing. So, but there is no hard and fast rule. So they can, if they create a scenario of CPR, they can ask you this thing. Usually this will not be, most probably it will not be asked in the long case or table viva, but it's a talk station. It can be asked in the talk. Okay, so this finish is CRRT, rapid response team, and code blue team. RRT, you can mix it with renal replacement therapy. Yes, Zishan.
Sir, code blue team के members कोई specific
Please talk in English. Code blue team. No, not specific.
Are there any specific members?
No.
So they are specific, sir.
What sort of specific?
Sir, there should be some specific people, specific team that should be notified that they will be available for CPR.
That is perfect, because of course there will be a pharmacist. I told you that in any team, but I'm telling you, when they are doing CPR, maybe pharmacist is the one who is providing the medication. That will be extra maybe. Okay, but in the team which they are doing it, you see team dynamics, what they say, every person should be know like what to communicate and how to communicate. This is one thing, and that people should be knowing their role. Okay, so there is no specifics at that time that nurses cannot do CPR. You understand? I can understand what you are saying. Am I right? That's what you are saying, that there is one person from this one like nurse or doctor or ICU doctor or emergency doctor. You are saying like that. Am I right?
Yes, sir.
Okay, sir, there should be, there should be at least one doctor who is qualified in this CPR or ACLS.
Listen, this is irrelevant talk. Why I'm telling you? Because according to the international standard, there is no hospital or there is no place in the critical care facility who is without certification. So the word you are using, certification is not mandatory. Atik bhai, do you understand?
Okay, sir.
I will just rephrase your word, that the people who are doing it, of course, all of them should be ACLS certified. You understand? How can they do the ACLS? How can they do ACLS without not being certified? Because you are telling in the scenario of Pakistan, okay? But we are still in the progress of implementation of these things. But internationally, because when we are talking like that, so you can use the word that there will be no person who is not qualified in CPR. Yes, that's what I told you, the team dynamics. The team leader should be the one who will be designating, and he should be knowing the limitation. Like for example, if nurse who is not equipped with the airway management, how can he or she can intubate? The intubation will be done by the trained personnel of ICU doctor or anesthesia doctor. Okay, so that usually we are being called. Maybe actually anesthetist is not the primary responder. Maybe at some time. Okay, because it not necessarily, because the emergency doctors can also do the intubation. So, like, I hope you understand my point. What I was trying to explain to you. That
Yes, sir.
there is no point that you will say that the person in the team only one there will be one person who is qualified. No, all should be qualified for providing the care. Okay, so that's the only thing which I wanted to clarify. Otherwise, you are absolutely right that the person, there should be specialized people for a specialized work. Okay, I hope you are clear.
And sir, the last thing that I should mention it, that after the CPR, if the patient has come in return of spontaneous ventilation, the patient should be shifted to ICU for further management.
Yes. Okay, so now next team quickly we will do is critical care outreach team. So critical care outreach team, the concept of critical care outreach team is that the patient is shifted from ICU to step down, okay, or step down means you can say HDU, okay, or now from HDU patient is transferred to the ward, and now there are some of the services which can be provided rather than being shifted in the ICU, but they are helping in guiding in the patient management, okay, and like they can just help in redeterioration, okay. Okay.
Sir, okay.
Yes, sir.
Fine.
So
Yes,
anything, because it's again, no, this is a very boring topic, but because this is in the articles it's written, so now articles is accessed by everyone, okay, and they can create this question. Maybe it looks a little like non-practical. It's not written in any book, so you can find some articles in the ICU folder. I will try to post the links for that as well, okay, and the support will be can be the same one which they are providing. Actually, there is no clear-cut distinction. They will be providing the same care which they were giving in the ICU. Like they can guide in fluid resuscitation, they can guide in oxygenation, they can guide in a neurological status. Okay, so this is actually
sir, in
yes.
In this critical outreach team, sir, the role of critical outreach team is to follow up whether the patient is deteriorating or not deteriorating, and share the critical experience with the ward fellows, and to prevent further readmission in the CCU or
okay.
HDU.
So actually it's almost the same thing which actually you can say that the other team is doing, okay. So but it's a little bit, and actually outreach team is also providing out of hospital care. Like the patients who are on long-term care, they are also providing them the support. Okay, it can be tracheostomy care, it can be when they are trying to go back to their normal, like it can be the physiotherapy care. So all the care which is provided after being shifted from ICU, it can be psychological support as well. It can be like there is a term, another topic which they can ask you is post-traumatic stress disorder. We will discuss at some point of time. So their role is also to identify the patients who are going in this stress disorder. Okay, so this is some words which they can ask you if they will ask you about critical care outreach team. They are expecting these few points to be mentioned by you. Anyone wants to add something? Yes. Anyone wants to add something?
Sir, in the critical care outreach team, we can prevent deterioration when patient is having chest injuries or some peritonitis or some abdominal injuries or some pancreatitis like picture by just following up. And
No,
and we
Atif,
can.
yeah, yes, you are right. But I'm telling you that there is no specific word for it. There is no specific for it because it can be any care, post-surgical, post-medical, it can be anything. The reason for which the patient was admitted will be the one to take care of. Okay. For example, if patient is weaned off and shifted, now patient maintaining, now the respiratory system is under consideration. If patient is post-surgical, these things which you are telling will be consideration. Okay. May patient needs, patient remained on inotrope or vasopressor, now finish, and now you shifted the patient. Now you will see that whether the patient is needing again those things. So this is the broad concept of critical care outreach. Okay. So next theme is what is acute?
In some hospital, it's also called as the acute care unit.
Acute.
You know,
acute care unit. Actually, the same part is the rapid response team, and same part is critical care outreach team. Okay.
In some hospitals also called as a step down unit, or step down
unit. Yes.
Okay, and and then for some time, they observe sometimes after admission from the emergency, sometimes from the ICU, sometimes from the operation theater. If patient stable, then they transfer to to the ward, and if deteriorate, then back to the ICU. For
yes.
Yeah.
Okay. So next team is acute pain service. Okay. So what is the concept?
Are there any specific members for the critical care team?
Listen, I'm telling you again and again, the same ICU doctor, pharmacist, charge nurse, they almost the same thing, and it can be hospital based. They will not ask you too much details, Ishan, so don't worry about it. If you tell these words, that will be enough for you to pass this question. Okay, you understand the concept. The patient who was in ICU and now shifted back, what will be needed? These will be the things which will be needed. Okay, so it can be a critical care doctor, nurse, pharmacist, physiotherapist. Whatever you are telling, you can tell. There is no specific names for it. Okay, usually what I told you, the charge nurse, pharmacist, physiotherapist, ICU doctor or anesthesia doctor will be part. Okay, so what is the concept of acute pain service?
Most of the time covered by sorry. Okay, please continue.
So please continue. So the purpose of acute pain service is to release give relief to the patient for deteriorating of comorbids like or sir, I can say arrhythmia, etc.
No, 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 no. Atik bhai, you are telling wrong. I'm sorry. Sorry to interrupt you. Just
sir, to reduce the stress response, sir.
no, this is not the purpose of acute pain. Try to be simple. Who is the person who will be needing it? Just tell me. What will be the domain? The patients, post-surgical patients. Either that will be post-surgical patients or patient presenting in emergency, the acute pain crisis. Okay. So that dedicated team will be visiting it, because either the patient will be on PCA, patient will be on epidural, okay, patient will have any wound catheter, patient has anything like that. Okay. Okay, Atik bhai, you are telling the right thing, but that is not the first thing to say. You understand? Yes, Atik bhai, can you hear?
Yes, sir. Yes, sir. I understand.
The purpose of acute pain is to follow the patients who were in OR, now having epidural or PCA, okay, or they are having breakthrough pain, which was not being controlled. So now they are calling you, and that patient can be that this breakthrough pain or acute pain can be either not necessarily in the post-surgical patients. It can be any patient, okay. The hospital which are providing acute pain service, any team, any patient which is unable to be controlled by the primary team, they can consult acute pain service team. Usual painful crisis can be in the porphyria, sickle cell disease, acute decompensation in a cancer patient, post-surgical patients, anyone. Like you can tell, then you can tell any story. Because why I interrupted you, because you were telling the stress, this is there for every patient, okay, but the concept of acute pain service primarily is the one which I have told. And now again the question which Ishan asked, that who will be the component? The same component: acute pain doctor or anesthesia doctor, pharmacist, charge nurse, okay,
Surgeon,
surgeon not necessarily. Surgeon, what is the role of surgeon?
Sir, in their article there is the name of surgeon.
Forget about it. The name of surgeon will never be, okay, you can count it, but primarily surgeon can be there, physician can be there, then you can add anyone. But the main purpose is that the charge nurse will be telling you about the comorbid, what is the purpose of it. They will be evaluating the comorbids, age, sex, condition, any drug interaction, okay. So the role of pharmacist is or charge nurse is that one, and you are the one who will be assessing according to the pain severity scales, okay. And if you are monitoring the PCA, what you will be seeing, how many attempts were done, how many attempts were done, how many how much dose was required, and was the patient satisfied or not. If the patient is not satisfied, either you will go for increasing the dose in the form decreasing the lockout time, increasing the bolus, or creation of baseline infusion, okay. So this can be one you can increase the dose, you can consult, the acute pain service can consult other people which are being required. For example, if
what is the purpose?
Yes. What is the purpose of what?
What is the purpose of acute pain scale, sir?
Acute pain scale?
Acute pain service is to decrease the morbidity and mortality.
Yes, that is an obvious answer. I am not saying that you said that a stress response need to be minimized. That's not the wrong answer, but that not the first breaking sentence. The breaking sentence is the one which I told you, okay. Because if you are trying to, if you are starting from a wrong way, it will not create a good impression. I understand that you have not told the wrong thing. You were not, your order was not correct. The purpose of whole of this story is to reduce the mortality and morbidity, okay. Okay, so some words about chronic pain team. Almost the same thing, but usually that will be related to cancer, or patients on palliative care. Okay, so they will be usually dependent on opioids. They will be needing, they will be usually it's an outpatient service. Okay, usually they will be outpatient service, chronic pain team. And Jamil, if you are mentioning sickle cell disease, even if they have chronic pain, but usually they are presenting in acute crisis. So actually there is not clear window between acute pain service and chronic pain service. Usually chronic pain service is for
Yeah, I 100% agree. But if they come with the acute pain episode, then it's managed by acute pain management services. But most of the time they have appointment every time, they visit to the pain clinic.
actually
And,
then it will not be the chronic pain team. Actually there is no, you are absolutely right, there is no clear distinction between these things. Okay, you can say, and you have a lot of margin to say anything in this scenario. So chronic pain team can be part of palliative care which they are giving. Okay, because that patient will not be coming, palliative care patient will not be coming to the clinic. Okay, that patient will be in the ward, so chronic pain team will be covering with the patient, and they may be needing to optimize or increase or decrease the opioids. Okay, they are helping them to add some adjuncts. Okay, so and they are following usually the WHO step ladder. You can say the same thing for acute pain service team and here as well, but it will be in the reverse direction. For acute pain, it will be from maximum to minimum, and in chronic it will be from minimum to maximum.
Zishan,
Yes,
Zishan, sir, what should be the level of the pain that that should be treated? It should be above the 3, or should be less than 3. Then it is the patient is okay.
Atik bhai, I don't understand your question. You are telling that what sort of pain should be treated?
Yeah. No, sir. I'm asking about that. Nurse is calling you that the patient is having pain. So what should be the criteria that the patient is on visual analog scale? It should be more than 3 to 10.
Actually, because I told you that I am short of time. This is not the topic for pain severity assessment. That is a separate topic. We will discuss, inshallah. My aim was just to tell you the concept of teams. Okay, assessment will be assessment. Assessment will be doing separately. Okay.
Okay, sir.
You can tell. You are asking questions, so you know the answer. You tell, please, rather than asking.
Sir, in my opinion, there should be it should be less than 3 when we are going to treat the patient that's having APS. Then the people in APS should decrease the pain to the level of 3. It should from 10 to it should be less than 3, sir. I was telling this.
Okay, patient should be pain free. I think I don't know from where you are reading, but you are telling something which is not required. Believe me, I don't understand. Okay. Patient should be pain free. Patient should be pain free. Why you are telling why you want the patient to still have pain 3/10? Just tell me.
It should be, sir. I was telling it should be less than 3, sir.
Pain free. You are don't make complicate yourself. You are assessing the patient. Nobody will be expecting this answer what you are trying to tell. Okay. You pain free. Patient should be pain free. That's it. Okay. You use the word pain free. Patient should be pain free as much as possible. Because this is I'm not able to swallow answer. Maybe examiner will also have the same feeling, because this is unnecessary. Okay, Atik bhai? The purpose of acute pain service is to identify the patient who needs immediate intervention for pain, for the pain control. The patients who are on PCA or epidurals, they may need bolus, they may need increase, adjust the dosage. Okay. And the purpose for you is to identify and give help to the primary team to adjust the dosage or increase or add something. That's it, to have the best possible pain relief. If you will give this answer, I guarantee you they will not ask you what you want to decrease the pain score less than 3 or not. Okay, because you don't need to reproduce the words of articles, please, I request you, because this is a complicated answer which you were trying to tell. Okay,
sir. Okay.
So acute pain service, chronic pain service will be that they will be identifying the patient, because palliative care is combination of some surgical procedures, some pain procedures, some neurolytic blocks, sympathetic blocks, or psychological counseling, or even end of life support in the form of propofol infusion of the patient of end stage cancer. Patient is vomiting and vomiting and vomiting. Okay, and patient is in severe pain crisis. So even they are initiating keeping the patient in ICU or with a propofol infusion just to ease out the life. Okay, so it has broad spectrum with palliative, because palliative care is being asked in the exam. So palliative care is part, chronic pain is part of palliative care. Okay, in that you are treating the opioid replacement, opioid addiction. You are identifying the patient who are needing the neurolytic blocks, but before that you will be giving some sympathetic block. So this is the part of chronic pain team. Okay, so I told some more teams, IV access team. So what will be the different? Atik bhai, I'm expecting a good answer from you. What are the different ways when patient is not having good IV lines, they are failing, and they are calling the acute IV team? What gadgets or what thing they can have? Yes, please.
Sir, there should be some instrument on which we can use ultrasound as well, and we can use as well.
One. The answer should be starting from ultrasound. What the thing which you were saying was irrelevant. Ultrasound, number one. Number two.
Sir, vein image, vein
visualizer or vein imager. Okay, two.
Vein visualizer. Vein.
Number two. Number three.
Number three is sir. We can have some.
You will exclude this. We can have some these words from your words. Be silent, okay. Think and speak, because it will not create a good impression. Number one, ultrasound, vein visualizer, intraosseous line.
Intraosseous line, sir.
At the last resort, intraosseous line will be there, and you can start your wording with that. Different size of cannulas, different types of cannulas. Okay.
And the expertise as well, sir.
Yes. Okay. So maximum these things which they use, or last thing will be venipuncture. Okay. If failed everything, then it will be venipuncture. Okay. I apologize.
The venipuncture or the venous section is I think it's not our privileges. It's surgical, you know.
IV team not necessarily. It should be anesthetist.
Only the IV team can go for, if they are expert, they can go for central line, but not the venipuncture.
Central line, yes, central line actually for anesthetist. IV team is not doing central line. Central line is for anesthetist, I think. But again, this is a gray area. You can say, I will just interrupt for a minute. Asghar Khan, I'm sorry, I could not take your question. Please, can you tell what you were asking? Asghar Khan. Asghar Khan was asking, the hand was raised, but I was listening, so I couldn't ask. So please, Asghar Khan, you are free to ask. Okay. So,
sir, excuse me, sir. In emergency situation, can we use external jugular vein
that one in the neck? Atik bhai, if you are trying to start your answer, difficult IV team will be doing the same thing. They can try different approaches. They can apply different veins. They can try different cannulas. Butterfly, for example, I'm giving you just example. Okay, different types of cannula. They can have the positional strategies. Okay, but they can involve the anesthetist to have central line. I don't think so IV team, because usually they are nurses. IV team is not doctors. IV team is nurses usually. Okay, so IV team is the one which I have seen at King Faisal. They were only nurses. Okay, these were the nurses.
Me also covering the difficult IV line.
That is a
We
burden
also
on you.
Especially,
That is a
sir,
burden on
obesity.
you.
Sir, obesity.
Okay.
patient is
Oh, okay.
the
I'm really sorry. We have to finish, so I might not need take last team which I want to tell is anticoagulation team. Anticoagulation team is the one. For example, if a patient is going for any procedure in which they have to convert the warfarin into heparin and combination with the Claxane, or any typical scenario, they will be comparing. They will be overall assessing the patient, and their main theme will be to compare between thrombosis risk and bleeding risk. Okay, and according to the risk of surgery and overall comorbidities and the problems, if they stop or if they continue. So these are the one they will be deciding. Either they will stop, they will decrease anticoagulants or antiplatelets, they will stop it, or they will do bridging. Okay, so this is the specialized team of usually cardiologists. Okay, usually they are cardiologists, and they are the one who will be evaluating and controlling it. Okay, so sorry to interrupt you people because I was short of time today. So we will try to cover the topic of burn tomorrow. Okay, and the interruptions which I did, Atik Bhai, I hope you understand that you have to use the meticulous words. Okay, you have to be systematic and you have to be in meticulous words so that you don't miss the important failure points. Okay.
Sir, excuse me, sir. If there in the cardiac surgery, sir, or aortic surgery, especially, we will use this. There should be anticoagulant team.
Yes. I told you the main rationale of anticoagulation team is to identify the bleeding risk versus thrombosis risk. Because if you continue anticoagulants or antiplatelets in the perioperative period, there will be risk of bleeding. If you stop it and there are risk of thrombosis, patient will have embolic phenomena. So they have to compare these two risks according to the risk of surgery, bleeding, and according to the thrombosis and according to the patient comorbids. So they have to decide whether they have to stop, whether they have to continue, or whether they have to bridge. That's the maximum what the concept of anticoagulation team. And this anticoagulation team concept you can tell in any patient in which you will be facing similar scenario. Okay. Anyone wants to add to the discussion? So we will finish. Disaster management team, actually, yes. Organ donation team, they will be getting the information from an ICU when the brainstem death is confirmed. Okay, and they are a group of people who will be communicating with the patient's family. Okay, taking the consent. Or in Western countries, there can be some will which is already there. So that patient can be categorized in either of them. Okay, and then they will explain the procedure, and then they will make sure the optimal conditions for organ donation is maintained. So and they will be communicating with the surgical teams who will be doing the harvesting. Okay, so this is the concept of organ donation team. Disaster management team, you told that it will be a combination of different people who will be in like they are in the services who are bringing the patient from any disaster site. So they will be combination of ACLS and all the ATLS care they are giving. Okay, and multidisciplinary team can be in any scenario. Okay, so I will finish my words with the member of team for placenta previa, Acreta. That team will be ICU, intensivist, anesthetist, obstetrician, and this one radiologist, interventional radiologist, general surgeon, urologist, hematologist, blood bank, OR staff. They are communicating and taking a decision of all the care which is being needed. Okay, and patient transfer team, nothing specific. The same people who are doing this care, they will be in the patient transfer team. There will be a doctor, there will be a nurse, and there will be the paramedical staff who will be extracting the patient from the ambulance, or and that's it. Okay, so I hope
sir, organ donation team is there's transplant organ the transplant organ surgeon as well, sir.
Yes, I told that.
No, I disagree this. In transplant organ donation, there should not be the member of that person who's going to transplant the organ, and not any single person should be the part of that team.
As Jamil, listen, you are right. Let me clarify this thing. Organ donation team is the one who is collaborating with everyone. Okay. Organ donation, the surgeon is not in the team, but they are collaborating. Organ donation team is the one whenever there will be a patient in with brainstem death in ICU. This is one category, or if there is living related donor, so that will be also be done by the organ donation. That it's not necessarily from the cadaveric. Okay, there can be a live patient donor as well. So the purpose of organ donation team is to collaborate between the donor and the recipient and managing all the things. That's it. There is no to facilitate. Surgeon, Atik bhai, surgeon, how can surgeon be in that team? Surgeon is being communicated.
It is not the sir, it is not the team that is announcing that, or it is claiming that organ brain death consider kar rahe hain na, sir.
No, you are mixing it up, please. That will not be, that is not part of organ donation team. That is being done by the ICU doctor for brainstem death. Okay, that is from brainstem death. You are mixing the things. That's what I'm starting my discussion from that for that topic. Organ donation team is being informed when a patient is having brainstem death, or if a patient who is a candidate for organ transplant and it is being it's being donated by the some of the relative. Okay, according to the country protocol, according to the religious protocol. Okay, so I will finish my topic here. Please don't try to I am trying to minimize the complications, and you are trying to entering into complication. Okay, please try to save yourself from disaster, because in the exam, if there is disaster, there will be no disaster team to help you. Only your words will save you. So try to be very simple, try to be very logical. Okay, so then you will not be complicate yourself. Okay, so because you see, you are only thinking about one side. I told you that organ donation can be done from a live donor as well. So what will be the role of brainstem death and everything? Okay, so that's what I wanted to tell everyone. Thanks a lot. So we will do the topic of burn tomorrow. Okay, bye.